The next topic is, do all patients with intraocular TB require co-administration of oral corticosteroids with anti-tubercular treatment? And we have debating on this Dr. Sharanya Abraham, who's the Associate Consultant Uveitis from Shankar Nethralaya. And against the issue is going to be Dr. Sai Bhakti Mishra, who's a consultant from Uvea from Narayan Nethralaya. So let's hear this interesting debate. On to you, Sharanya.
Thank you, ma'am. Are my slides visible?
Yeah.
So we'll take it as three cases, which we'll discuss again in the end. The first case is a patient with pan-uveitis who's been on regular follow-up. His vision at this point was 6/9 and 6 while on 10 milligrams of oral steroid. He was on Azoran twice a day and was on ATT as his TB tests were positive. So he came back at this point with this subretinal fluid that you can see and reactivation around the scars. The scars were quite dormant for quite some time. At this point, we suspected he could have had a subretinal abscess and did an ultrasound. The second case is of a vasculitis in the right eye and a vitreous hemorrhage in the left eye. The patient was on steroid and ATT. He underwent PRP, and this is how he looked. He came back while on 12.5 milligrams of steroid on Azoran twice a day and in the fourth month of ATT with a drop in vision. At this point, an OCT picked up that although the rest of his fundus looked quite stable from the vasculitis point of view, he had cystoid macular edema. The third case is a patient who was already started on ATT before he presented to us. He had a macular GHPC with lesions very close to the fovea. His vision was 6/12 and 6. So tubercular uveitis is something that can present as both fundus lesions, anterior segment lesions, anterior uveitis, infective scleritis, a host of presentations in the eye. The good thing about TB and its treatment is that the lesions either melt away completely or they scar. This is with systemic steroid. So this uveitis may be due to an active ocular infection by the tubercle bacillus or an immune-mediated reaction to latent TB infection. Prospective longitudinal studies have analyzed the presence of serum cytokine profiles in patients with tubercular multifocal serpaginoid choroiditis receiving both ATT and oral steroids. So the analysis was done in two groups, those with and without paradoxical worsening. What that means is we'll come to in the next few slides. In conclusion, they found that the baseline IL-10 levels were a little higher, including early rising levels of interferon gamma and an increase in transforming growth factor beta and tumor necrosis factor alpha. All of these are pro-inflammatory cytokines. So these are increased after the initiation of ATT and corticosteroids. MTB in itself is capable of stimulating the release of IL-10. This is an important point when we start patients on treatment. The standard anti-tubercular treatment that we follow, the recommendation is a 4-drug regimen with isoniazid, pyrazinamide, ethambutol, and rifampicin for 8 weeks or 2 months, followed by 4 months of 2 drugs. This is applicable even in HIV-infected patients. So a paradoxical reaction while on ATT may consist of either clinical or radiological worsening of a pre-existing TB lesion or the development of a new lesion in patients who showed an initial good response. There are various hypotheses for this. One is the reconstitution of the immune response itself to treatment. The other is an elevation of the TNF alpha levels stimulated by lipopolysaccharides in the mycobacterial cell wall. This serves as an initial step in the pathogenesis of paradoxical reactions. Bacteria-laden macrophages from the alveoli might directly enter the lymphatics and circulation, thereby carrying the bacteria to the eye where the organisms persist and initiate an immune-mediated response. The common thing is the immune response. A Jarisch-Herxheimer reaction systemically has been described in syphilis very early on, and this characterized by a worsening following chemotherapy. Here too, circulating cytokine levels are high. Complications include all ocular neurosyphilis and cardiovascular syphilis. Steroids are known to suppress an initial JHR, and this kind of a reaction has been seen in the eye in a patient with proven cervical lymphadenopathy. The mechanism of GHR is endotoxin release, delayed hypersensitivity, and a decrease in the suppressor mechanisms. Although it is seen mostly in syphilis, other systemic diseases like leptospira, Lyme disease, systemic disease where the worsening can be in the form of intracranial tuberculomas, meningeal disease, TB, radiculitis, pleural effusion, and abnormal TB exist. These are some articles that describe a paradoxical worsening. In all, there is a worsening of the patients while on ATT, either in the form of new fundus lesions or in the form of systemic worsening, including intracranial tuberculomas. These patients are successfully treated with either intravenous or oral steroids. All of them did well with oral steroids. A recent article shows the treatment of tubercular granulomas with anti-VEGF injections along with moxifloxacin.
1 minute
In
remaining.
10 out of 10 patients in this study, all of them received a standard care, which is corticosteroids.
1 minute remaining.
We go back to the first case. This patient, we hiked up the steroids, increased the azoran, continued the ATT. We see a resolution of the lesion with scarring. The third case also added oral steroid, continued the anti-tubercular therapy, gave him IVMP, and started Azoran. The lesion has disappeared. Vision is back to 6/6. In conclusion, from existing literature and clinical practice, steroids remain pivotal in the management of inflammation in TB uveitis, thereby preventing sight-threatening complications from any coexistent inflammatory process. To answer the question, do all patients with intraocular TB require oral steroid with ATT? The simple answer is yes. Thank you.
Thank you very much. That was a very